I hope the screen is visible and I'm audible. If somebody could just put it in the chat that it's visible and audible. Yeah, okay, fine. So let's start talking about MRI. So like I said, the X-ray and the CT in post-op spine, Dr. Aditya Daftri will discuss it next time. Today we'll be looking at mainly MRI only. So if we talk of post-operative spine, we are looking at recurrence of the symptoms that required surgery to begin with, or new symptoms have developed. And this is like a meme, but something which is right. So this becomes a very challenging area of imaging. Obviously, the patient is very unhappy and irritated, and because he's got symptoms again, the surgeon is again wondering what has happened, why the symptoms are back again. And the condition of radiologist becomes something like this, where it can be a challenging because early post-operative imaging versus the early post-operative findings and pathologies can have very similar looking imaging appearances. So when we look at complications, we are looking at early post-surgical and late post-surgical. So mainly we'll be discussing infection. There can be residual or recurrent disc herniation. You can have arachnoiditis. There can be recurrent stenosis instability. So these are the various common causes that we'll be looking at. Before we even start looking at MRI, it's very important to know what was the initial clinical findings, what was the diagnosis, what exactly was the surgical treatment which was done, and how much time has elapsed between the surgery and the scan. So what was the time of the surgery, very important, and currently what is the patient presenting with. The protocol that we use, the sequences that we do are T2 and T1 sagittal images. T1 and T2, usually you may also do T2 fat side, but plain T2 also suffices. Axial images, corneal stir images, which I haven't put the picture here. And also majority of these cases, we give contrast. Now, when we give contrast, we need to scan immediately. You don't want to wait too long. Why? I'll just come to that later. And we obtain axial images and then sagittal fat sat T1 weighted images. So this is one situation where we may get away without giving contrast, but majority of the times we do prefer to give contrast. Now, this is the most tricky part in post-op MRI of spine, that you have to differentiate the abnormal findings from the acceptable and expected post-operative findings after a successful surgery. And this is where the whole difficulty lies on MR. Now, immediate post-op, for example, in this patient with discectomy, what you can see is you can clearly see some marrow edema in the inferior end plate of L5, some bright signal within the disc. You can see a tract here like this at the site of surgery. And if you give contrast, you will see peripheral enhancement. And all of these are within the realm of expected post-operative changes. Some post-operative fluid collection, some enhancement around the nerve, something which looks like a disc. So if you look at this, this looks like a disc herniation itself. So sometimes the post-op image may look more, the lesion, this area may look larger and more worrisome than the pre-op imaging. But these are just expected post-operative changes. For example, here again, this was early, and you can see this post-operative fluid collection. And this is about few months down the line, and you can see that whole collection has completely resolved. Now, in the early post-op phase, when you are doing imaging, it is usually not done in that early stage. But in this case, hematoma was suspected. And what we can see is on T1 as well as on T2 weighted image. Let me just get this. You can see this large lesion. It's right posterior epidural, as well as going through the laminectomy defect into the posterior paraspinal region. On T1, it is similar to muscle or slightly brighter. It's not as dark as fluid should be seen. Here is the lesion. And more important is what it is causing. This is the thecal sac. So it is causing about moderate to greater canal stenosis, and you can see that the thecal sac and its nerve roots are compressed. So this was an epidural hematoma. You may have hematoma, and more important is how much of a mass effect it is causing, and that could lead to complaints. In a later or more chronic, you may have arachnoiditis, common with any spine surgery. If olden days when you had the oil-based dyes like myodil, which were used for myelograms, then you could have, or it could even be following epidural steroid injections. What do we see on MR? So on MR, if you look at this, these are the cauda equina nerve roots. So these are the normal ones. But here you can see this area as well as this area, these cauda equina nerve roots are thickened. This is the MR T2 weighted image. This is contrast. This is also contrast. So on contrast, you can see that these cauda equina nerve roots are enhancing. Normally, the nerve roots don't enhance so much. Here on these axial images also, you can see all these nerve roots are thickened and showing enhancement. So this is suggestive of arachnoiditis. The other appearance could be, if I look at this is the normal. This is normal for comparison. Here you can see how the cauda equina nerve roots are distributed evenly kind of towards the periphery. And in this patient, all the cauda equina nerve roots are clumped. There's nothing compressive here, but they are clumped. It looks like a spinal cord almost. So it's like a pseudo cord sign. So that's a sign of arachnoiditis. The other appearance could be, this is normal again. You can see how cauda equina nerve roots are spread evenly. Here, if you look, this is the thecal sac, and it looks like the thecal sac is empty. So this is called empty thecal sac sign. But when you look, you can see along the wall, you have this. These are all the nerve roots which are clumped and stuck to the, adherent to the periphery of the thecal sac. So the thecal sac may look empty, or it may look like a pseudocord sign because they are all clumped together. Here the nerve roots are clumped and adherent peripherally. Now, there could be canal stenosis, especially what happens is, for example, here, if I look at the AP dimension of this spinal canal on T1 weighted image, it's very narrow. Again, here, if I look at the AP dimension, it's this narrow. So due to developmentally short pedicles, you may have bony spinal canal stenosis. And if this has not been mentioned or this has not been evaluated, and if a very minimally invasive surgery is done, then it is still possible that the stenosis may not be completely relieved. So here also, if you look at it, how it's almost like a trifoliate-like narrow appearance of the canal. So even though surgery has been done, but because of the developmental bony spinal canal narrowing, you may still be having symptoms. Recurrent disc herniations are common. So for example, here you can see this. This is the level at which surgery is done at L4-5. And what you do see is this hypointense area. It is looking less dark as compared to the adjoining disc. But when I give contrast, what I see is it is showing peripheral enhancement. The central portion is not enhancing. These are the axial images. This is T1 weighted image. This is the disc herniation. And this is the thecal sac here, which is getting compressed. And here you can see this disc herniation is showing peripheral enhancement. This is because the disc is avascular, so it does not take up the contrast. Only peripherally, some contrast will be imbibed. And that's the reason we should do the scan immediately after injection. You should not wait for longer after injecting contrast, because with longer time, kind of contrast diffuses inside. And even a disc may show some enhancement. Next, we are looking at epidural fibrosis. Now, epidural fibrosis will always occur in all patients, almost all patients after surgery. But what we need to see is it significant? Is it causing any mass effect or so? Now, here, if I see, this is the nerve root, and adjoining it, all of this around it is epidural fibrosis. So the epidural fibrosis, if it shows homogeneous enhancement. So this is all the epidural fibrosis. You saw the disc earlier. which showed peripheral enhancement on injection of gadolinium, which is the MR contrast. While here, a similar looking lesion, but it's showing enhancement all inside, and that is sign of epidural fibrosis. So we need contrast to differentiate between epidural fibrosis and recurrent disc. But if this epidural fibrosis is not causing any significant deformity of the dural sac, or if it's not causing any nerve root compression or encasing it, or nerve sheath is effaced, then it can just be normal. I mean, it can be a finding post-operative, which may not be causing anything. So initially, there is granulation tissue, which over few months becomes epidural fibrosis. So here's an example. These are the early, say, May 2013, the scan was done. And you can see how you have a lot of soft tissue here, which is kind of around the nerve root. And this is about a year later, and you can see that this soft tissue has now significantly decreased. So the epidural fibrosis kind of retracts. For example, here in this patient, you can see these are the dorsal nerve root ganglia, the exiting nerve roots, and just adjoining it, you have this iso-intense area, which is showing enhancement and which is abutting or slightly impinging the nerve root. So this would be significant there. And the patient should have symptoms also corresponding to it. Here, for example, another case, you do have this disc herniation, but on contrast, what you see, these are the nerve roots, and they are completely encased by this enhancing soft tissue. So you have this epidural soft tissue. This is the thecal sac here. These are the nerve roots. So all this epidural fibrosis, there is significant. So once again, just to recap, how do you distinguish? A disc will show peripheral enhancement. On contrast, that enhancement means it becomes bright, while this is a nerve root. These are the two nerve roots. So the soft tissue, which is encasing it and is showing homogeneous enhancement, is epidural fibrosis. On T1 weighted images, it may be difficult to distinguish between the two. On routine images, sometimes they can look similar. A dreaded complication would be post-operative infection. And what do we see here? This patient has had posterior decompression from L3 to L5. This enhancement in the posterior paraspinal soft tissue and all these susceptibility artifacts are expected post-operative changes. But what is abnormal is on STIR image. This is STIR image. You have bright signal in all these vertebral bodies. You have T2 bright signal in all these intervertebral discs. You have anterior and posterior epidural soft tissue component. When you give contrast, you can see these intervertebral discs enhancing. You can see these vertebrae enhancing, and you can also see the enhancing anterior epidural and posterior epidural soft tissue, which is causing compression of the cauda equina nerve roots and significant canal stenosis. But having said that, remember that MR, it may not always be easy to distinguish infection from early post-op change. I'll show you examples later. Here in this patient, you have a lot of marrow edema adjoining the disc and the end plates. So some marrow edema post-operative is expected, but this is much more. Disc is showing bright signal. On contrast, and you can see from the disc, you have this thin tract coming in into this fluid collection here. Again, the disc is enhancing. There is small pre and paravertebral soft tissue. You have this collection. On contrast, it is showing peripheral enhancement. Here again, you can see this collection well, and it was tracking to the skin where there was pus discharge. So there is spondylodiscitis infective involving the L5 S1. Now here's an example just to show how early infection can really be difficult. So this was just within first week or 10 days. And on MR, I'm seeing a little bit of marrow edema. The disc is still showing me dark signal. There's not much of bright signal in the disc. Something that looks still like a disc herniation-like appearance. I said post-op that can look like that. You have a tract going from the site of discectomy here. And you have this fluid collection in the posterior paraspinal region. On contrast, it's not showing much of enhancement, just little wall enhancement. So all of this can very well be within the realm of expected post-operative changes. So at this stage on MRI itself, can I call it infection? No. One has to take into account the laboratory findings, the CRP, the WBC count, those findings clinically, is there fever and all, and put it into perspective. So this patient, they were suspecting infection. On this, we could not confidently say whether it is infection or not. He was put on antibiotics. And this is a scan less than a week later. So now can you see, I just want you to see this T1 weighted image. There is very less marrow edema. And look at this post-operative collection. It's barely showing any peripheral enhancement. As against that, look now, the post-operative collection is smaller, but can you see how much the marrow changes contiguous along the vertebral bodies have increased? The T2 bright signal in the disc. If you notice here, there was not much bright signal. This is post-op change that we were seeing. And now here, clearly, the T2 bright signal in the disc has increased. The marrow edema around it has increased. On contrast, the enhancement around it has increased. This post-operative soft fluid collection has decreased in size, but it is showing much more thicker peripheral enhancement and edema. So all of this together clearly say this is infective spondylodiscitis. But at that first scan time, it's really difficult to say. This is another example. Post-operative, there was decompression at L4-5 and L5/S1. And now you can see later, you have this bright signal intensity within the disc along with epidural, anterior epidural soft tissue component. Here again, you can see it is this bright area. This patient had intervertebral fusion also done here, and this collection. This collection can still be post-op, but this is surely abnormal and this is infection. You may have a seroma or a pseudomeningocele, and we may want to see the communication with the thecal sac, which may not always be easy to see. So you may see communication, or sometimes it may be very slender and difficult. So here you can see this large fluid signal intensity of fluid collection at the post-operative site, laminectomy defect, and in the posterior paraspinal soft tissue. It has very thin, smooth walls, no debris, no surrounding edema. The patient did not have any signs of infection, and this was just a seroma. You may be able to demonstrate communication with the thecal sac. Here's another example. You have this collection. On contrast, it is not showing any enhancement. And you can see this is communicating with the thecal sac. So here it is communicating with the thecal sac. Instability. Now, what may happen is, because of decompression, the decompression being done here, this patient had a recurrent disc herniation, disc herniation, but also now because of this decompression, you may develop instability at a higher level. So if you have done multiple level decompression and fixation is not done, there can be antrolisthesis and instability. Regarding the hardware complications, Dr. Aditya Daftari will be talking about it in the next session. But on MR also, depending on what material. So here I would like to talk about MR safe and MR compatible. These are two things. MR safe means you can do the MRI, but there is no harm to the patient. So all the orthopedic hardware are MR safe, but it may not be MR compatible. That means how much artifact it is causing. Like for example, here, this is the pedicle screw. This is the pedicle screw. But around it, you have this area, which is susceptibility artifact because of the metal. And this can vary depending on the material used. If it is titanium, there'll be no susceptibility artifact. It will not affect the image quality. But certain times, especially in our country, you have so many different types of metallic hardware that is used. There can be a lot of susceptible artifacts. So much that you cannot visualize the adjoining spinal canal and the foramen. But still, in these patients, we obtain a combination of MRI with CT cuts to try to evaluate. So here you can see this pedicle screw is almost extravertebral in this paravertebral region, while this one looks slightly more medial. But again, as I said, CT might be better to show this. Similarly, you may have fracture of this pedicle screw, all of that CT. Dr. Aditya Daftari will be covering it in detail later. On MR, here you can see this interbody fusion device, and you can see how it has migrated posteriorly. So it's migrated posteriorly and causing the nerve roots are getting aborted. Here was this posterior epidural fibrosis soft tissue, and this is where there was canal stenosis, and this has migrated posteriorly. Here's an example. Now here in this patient, this was anterior cervical discectomy and fusion had been done. Titanium was used, so there's not much of an artifact. But in spite of that, if you look at it, this patient presented with left-sided radiculopathy. And on MR, there was a disc here, lower level, but that was central. And here we could not find any canal stenosis. But because there was clear radiculopathy at that level, a myelogram, CT myelogram was done, a myelogram and a CT was done. And what you can see here clearly are these large left paracentral peridiscal osteophytes, these end plate spondylosis changes, which was aborting the nerve root and was the cause of. So MR is good for post-operative imaging when you're looking for infection, when you're looking for epidural fibrosis versus disc, when you're looking at instability. But when you're looking at hardware complications and sometimes the osseous changes, MR may not show very well because of the artifacts, and a CT would be better. So many times we use a combination of both. So with respect to MR, remember that early post-operative stage is always a problem. It becomes very difficult to distinguish expected post-operative changes from infection. And this is when you need to take into account the pathology as well as the clinical presentation. Unusual causes have to be ruled out because before labeling the pain as functional, and we have to take the X-ray, MRI, and if required, CT, all of them together to make a diagnosis and decide the cause of the pain. So any questions, I would be happy to answer. And then we can kind of look back at the infection that we missed last time. Please feel free to ask questions. So contrast, usually we give in post-operative cases, but without it also, if the epidural fibrosis is prominent, then we may not give contrast every time. Infection versus recurrent disc, both peripherally enhancing, yes. But what happens is the recurrent disc on T2 weighted images is dark, like a disc, while infection is like a fluid collection, bright on T2. So that we can distinguish. Infection versus recurrent disc, not that much of a problem as much as epidural fibrosis versus recurrent disc. Various stages of hematoma, yes. So on MR, hematoma, early acute one is bright on T2, and on T1, it may still not be bright. As the hematoma becomes subacute, on T1 weighted images, it will be bright. So then the question, anything which is bright on T1 will be worried, is it fat? But for that, when we do fat suppressed sequence like a STIR or a fat sat T1, the hematoma will not suppress, while fat will become dark. Later, chronic hematomas can have T1 hyperintense areas, can have hemosiderin staining, which is hypointense areas at the periphery, dark areas at the periphery. How can we rule out infection versus hematoma? So if it is a subacute stage, it's not a problem because, like I said, hematoma on subacute stage will be bright on T1. Infection is not bright, it's dark on T1. But in the early stage, it can sometimes become difficult. And also, infection will have a lot of soft tissue edema around it. Any other questions? So the X-ray and the CT of post-operative spine will be discussed by Dr. Aditya more in detail later. Today, this was about MRI. So if there are no questions, I can move ahead to the infection part that some of you missed last time because I think we started at 8 o'clock. Or if there's anything else with respect to infection, or if you want me to show any cases of seronegative spondyloarthropathy is also something that we discussed last time. If somebody needs anything more, any clarification on that or for it to be covered, please put it in the chat box and I can do. So now I'll continue with the TB spine. I think many people started watching it from the atypical tuberculosis. The typical tuberculosis part was probably missed. We'll do that. Okay, so gadolinium enhanced scans so gadolinium is kind of used when required. So for example, in brain for tumors, infections, it's used regularly, but none of the MRIs are usually gadolinium enhanced scan all the time. For things like bone tumors, again, you'll give gadolinium all the time. But in spine, degenerative spine, most of the times we don't require it unless you have a sequestered disc component and that you are getting confused with a nerve sheath tumor. So sequestered disc will show peripheral enhancement, nerve sheath tumor will show homogeneous enhancement. Infection, again, if it's clearly infective, if there is an abscess which is fluid signal intensity, we may not give contrast. Tuberculosis, we may not need it. If you can't distinguish infection from tumor, if the soft tissue is, you're not clear whether it is abscess or solid, then you will give contrast. Post-operative spine, again, to distinguish between epidural fibrosis and recurrent disc. Also for infection to outline it better, we may give contrast. But remember, contrast, there is a cost involved in it. One, so not all patients are always ready for it. And also what happens is, though it's not common in India, because we give lesser doses of contrast as compared to abroad, there's something called as NSF, nephrogenic systemic fibrosis. And this in patients, so earlier people thought that CT contrast is not good in patients with impaired renal function, but MR contrast is fine. So nobody would even bother about creat and just give contrast in MR patients. But then in US, it was discovered that many of these patients would then go on with severe renal dysfunction. When given higher doses of gadolinium, they would develop this NSF. And what would happen is they would have lung fibrosis, they would have skin fibrosis, and this would be an irreversible condition. And if the lungs, too much of it was affected, this could even lead to death. So that's why what we do is we calculate more than creatinine, we calculate the EGFR by creat, patient's age, weight, and sex. By that, we calculate the EGFR. If the EGFR is below 30, we prefer not to give contrast unless you cannot make out from the plain MR and it's really indicated if the patient's on dialysis or things like that. Otherwise, above 60, we give easily. Between 30 and 60, we have to be careful about how much dose we are giving and give only if really required. And also, you have ionic and non-ionic MR contrast media, so you'll use the non-ionic one. What amount of contrast is given, it depends on, because depending on different brand and different the component which is there. So gadolinium is the basic one, but what it is mixed with, there are different ones, so different will have different doses. And based on the patient weight, yeah. Okay, so we'll just continue with the infection part. Yeah, so I hope my screen is visible. Yeah, is my screen visible? Yeah, okay. So this is for those who missed it last time. So TB, when we talk of, you have typical, you have atypical, and TB mimic. So I think atypical and TB mimics is, some people miss the typical part. So when we talk of typical tuberculosis, so when you talk of typical tuberculosis, it can be vertebral or it can be non-vertebral. Vertebral may be paradiscal, may be anterior or central. Atypical can be solitary, multifocal, or posterior element. Early tuberculosis, for example, here usually may have an anterior focus. So here in the anterior superior, let me just get this. So here in the anterior superior portion of the vertebral body, you have involvement, and that can further increase. Here you have got this pre and paravertebral soft tissue component, and this is the lesion in the bone, and rest of the bone, which is looking dark on T1 and bright on T2, that's all marrow edema. This is the focus of the infection. Or early TB can be paradiscal. So here, if you notice, it's more adjoining the disc, this focus here. Sometimes it can be central. Like for example, here you have this central lesion and a lot of marrow edema around it on T2. On T1 weighted image, it is dark with marrow. And this is after treatment where you can see there is fatty marrow. After this initial focus, this infection can spread to the disc and the adjacent vertebrae, forming your typical spondylodiscitis. Or it can spread longitudinally over multiple level. For example, here you can see this. It's under the anterior longitudinal ligament. It can extend for a very long extent. And at each level, it involves the adjoining anterior portion of the vertebral body. The discs, as you can see here, are spared. The discs are not bright on T2. So you can have subligamentous spread of the abscess. T1 weighted image. This is the normal vertebral body, which should be a little bright because of fatty marrow. So all these vertebrae are involved because they are looking dark on T1 and bright on fat saturated T2 weighted image. Or the infection can spread posteriorly. You can see this anterior epidural soft tissue component. You can see this large anterior epidural soft tissue component and left paravertebral soft tissue component, causing advanced canal stenosis and cord compression. So this vertebral body is involved, and then the adjoining vertebral body is also involved. Typical appearance on X-ray is like this, where you have two vertebral bodies involved, intervening disc is involved, showing irregularity, and this patient also has some paraspinal soft tissue component. And this is how you see on MR. This is the infective spondylodiscitis, where you can see irregularity, and then you can see it large anterior epidural soft tissue abscess, which is extending under the longitudinal ligament and involving the adjoining vertebrae, only the anterior portion. And here you can see the pre and paravertebral abscess. So abscess looks like this, where it is bright on T2. It's like fluid, okay? So then here, even without contrast, you can gut away with. But if some place you have a doubt whether this is fluid or solid, you need to give contrast. Again, classic appearance. And this is the stage we want to pick it up in early, when there's not much of soft tissue component, two vertebral bodies. This is normal T1 weighted image. Vertebral bodies look bright due to fat. And here you can see this dark signal. On T2 weighted image, it is bright and it is showing a small soft tissue component. The soft tissue component is much. There is early involvement of the disc also. So the soft tissue in tuberculosis, sometimes on this, it's not very bright. But when you give contrast, you can show it showing peripheral enhancement. So that means the central portion is all caseous necrosis. It is not enhancing. So here you can see this abscess. So peripheral enhancement tells you this is abscess. Remember that whenever you have a sinus tract, you need to trace it all the way up to infection. For example, here there was L4-5. You can see L4-5 prevertebral abscess. Now keep tracing this. It goes like this, adjoining the psoas and then the iliacus. This is a sinus tract, and it opens anterior to the hip joint. So sometimes we've even seen spine infection tracking all the way down along the iliopsoas into the thigh, and then coming out somewhere near the lower thigh or knee, you have a sinus tract. So remember to always trace it up to the osseous focus as far as possible. So this is the sinus tract here, anterior to the hip joint. Next, coming to the non-vertebral infection, it could be epidural, leptomeningeal, or intramedullary. So for example, here, in this patient, you have a posterior epidural soft tissue component like this. This is T1 weighted image here. This is T2 weighted image because the CSF is bright. Here CSF is dark. And on contrast, when I give contrast, it is showing smooth peripheral enhancement. The central portion is not enhancing. So this is an abscess. And here you can see this is the abscess, which is compressing the thecal side. So if it was enhancing solid, it would be a round cell tumor or lymphoma. Sometimes when patient comes with paraparesis, inability to walk, but there's nothing compressive. So now when I look at it carefully, I can see this cauda equina area, nerve root area, this thecal sac is looking very dirty. It should look bright on T2 due to fluid, but it's looking dirty. And when I look at this, I'm not sure what's happening behind this cord. Is this cord getting a little compressed? Is this normal CSF or not? So it's important to give contrast. And when I give contrast, I can see all of this cauda equina nerve roots all along it. There is enhancement. And see on the surface of the cord also there is meningeal enhancement. And you can see this peripherally enhancing epidural abscess posterior to the cord. So remember to give contrast. This patient also had S2 segment involvement with presacral abscess. Okay. This is another patient who had spondylodiscitis at this level. You can see these two vertebrae are involved. And this patient had a focal lesion in the cord, within the cord. With all of this is the cord edema around it. So disproportionate cord edema, small lesion. And when you give contrast, it is showing peripheral enhancement. This is intramedullary tuberculoma. Also on the surface of the cord, we can see enhancement. This is leptomeningitis. And there was a tuberculoma in the medulla, in the brain also. So that was typical TB. Atypical, we discussed that day, you may have a solitary vertebral body involvement, no disc involvement at all. And sometimes this can get difficult to distinguish from tumor like this, something like this. This is after, this was the initial one, and this is after treatment where it has improved. But initially it may become difficult to say TB or tumor, and you may need a biopsy for that. Again, solitary vertebral body, vertebra plana, but then you have an abscess here, so you know it is TB. Only posterior element involvement. So books often say that only posterior element involvement is usually metastasis or infection, but in our country that's not true. We see posterior element TB. Here you have a posterior paraspinal abscess with a spinous process involvement. Again, involvement of only posterior elements. Here also you can see there's a posterior epidural soft tissue component and the articular process involvement. Multifocal TB, even that can become difficult. So this patient had multiple lesions in the spine and one lesion in the tibia. So whether these are metastasis or TB can become really difficult at times. After treatment, so this is T1 weighted image. See how this lesion is dark. After treatment on T1, they have become bright. That means fatty marrow replacement, and that is suggestive of healing. CV junction tuberculosis, also common and can be extensive, especially in pediatric age group. Contrast here is showing this peripheral enhancement. And after AKT, you can see all the soft tissue component has significantly resolved. Multifocal involvement is very common in pediatric age group. So you can see involvement in these levels, this level here, here, large soft tissue component, same patient, lumbar spine. So you may have, it's quite common in India. TB mimics, we already looked at it last time. Most common being seronegative spondyloarthropathy, which can cause complaints. It can cause difficulty in diagnosing. Can we have something based on spine oncology? Okay, tumors, yes, we can do. And congenital spinal deformity, especially bifida and CV junction anomalies, yes, we can do that. Vascular anomalies of spine, okay, little we can differentiate that. Maybe what we can do is tumor. Tumor, you're looking at you're talking about the bone tumors as in the spine, or are you talking about the cord tumors? How do we differentiate between active abscess versus walled-off abscess? Yes. So this is a problem. See, on MR, we are seeing something as an abscess, whether it is active, and sometimes we have seen it remaining for years together. Patient is not, I completely agree with you. If it gets calcified or something, yes, we can say it is not active, but otherwise it can become difficult. And if everything else is resolving the bone lesion, then you can just take it as it's like just a small remnant abscess, which is remaining and follow up. Yeah. Okay, so we do have some time. One second. So bone tumors we are talking of. Okay. Is there any role of PET scan in it? Yes. So for follow-up, what happens in follow-up for spine TB? MR can show marrow edema persisting in it for a long time, even after the recovery. Also remember that the MR recovery lags behind the clinical recovery. So MR can show some marrow edema till much later, even when it's not very active. And PET CT in that can be helpful because PET CT will not show any active uptake. Yes. Usually on MR, we are looking at resolution of the marrow signal, abscess getting resolved. And third thing is this thing, the fatty marrow replacement. The marrow is soft tissue resolves, marrow signal resolves, and is replaced by fatty marrow. Metastasis on MRI scan. Okay, so what we'll do is we'll keep this for the last session, in fact. So I think we have 2 more sessions. Next session will be X-ray and I think one of the two sessions would be X-ray and CT of post-operative spine, because that's an important topic and we have a lot of issues sometimes, in interpreting that. And the other one we'll have tumors and what else was asked? Some congenital anomalies. Congenital anomalies and tumors is what we'll have a whole session on. And in that tumors, we'll make sure we include metastasis also. Severe osteoporosis versus multiple myeloma. So I did show this last time in the lecture when we talked about pathologic fracture versus this. So yes, in about 10% of the patients in multiple myeloma, you may not find anything abnormal on MR. In fact, let me just, if you can just hold on, I'll just check in my lectures if I have one. So MR will just show a lot of osteoporosis, and there'll be, even retrospectively, I'll not be able to say there is a trauma. One second, I'm just seeing this. If I could. Not this one. Give me just a minute. I have one. Yeah, okay. I'm not able to find it right now. So when you have multiple myeloma, you have, I'll show you how a multiple myeloma looks. That I can show you. Yeah, I'll just share the screen. Yeah, you can see this. So here on T1 weighted image, normal vertebral body in adults should be brighter than the disc. They should not be darker than the disc. So you already know something is wrong. Ignore this. This is bright on both T1 and T2. So this is hemangioma. But rest of the vertebrae should not look dark like this. And on stir image, normally vertebrae should look dark because they get, the fat gets suppressed. But here you can see how they are very bright and heterogeneous. So this is typical for myeloma. These are fat sac T2, and again you have diffuse involvement. But in about 10% of the patients, multiple myeloma can look only like osteoporosis, and MR may be normal. It's well described in articles also. Okay, so any questions? So what we'll do is that's what. So now we know what we need to cover in the next two sessions. One will be on post-op CT, and which one we'll just put it out in the group. And the other one will have a tumor and some congenital abnormalities. Yeah. Some articles to read. Okay, we'll do that also. We'll put it up on the group, some articles which are there. Yes, we'll do that. Thank you, everyone.
Thank you.
Good night.
Good night.